Hello, class, and welcome to the lecture. This is Dr. Lee, and you've made it to part 5, where we're talking about the pharmacology and toxicity of antineoplastic agents. And in this module, we're going to go over the hormonal therapy agents, specifically revolving around anti-estrogens and anti-androgens. Now, these are going to be for those hormonally sensitive tumor types, which are your breast cancers and prostate cancers. So, starting with the anti-estrogens, we have two different mechanisms for inhibiting estrogens. We can either bind specifically to the estrogen receptor itself and prevent estrogen from causing the tumor cell to have that proliferation signal and the anti-apoptosis signal. And we do that through drugs like tamoxifen, our selective estrogen receptor modulators. So these would antagonize estrogen receptors in the tumor cells, but stimulate them in the bone so that they have protective bone properties as well. So because of it's a selective estrogen receptor modulator where it could be an agonist in some tissues and antagonist in other tissues, the agonizing effect would be increasing the thrombotic risk as well. And also you would have this increase in endometrial cancer too because of the fact that it has this agonist type of effect too. So those would be the side effects of the selective estrogen receptor modules. And we also have drugs that would deplete estrogens. And so these are aromatase inhibitors, prevents the conversion ultimately from your cholesterol precursors into estrogen. And we have our common agents such as letrozole in this category here. Because it's depleting estrogen, you're going to have osteoporosis. So this is a vast difference to protective bone properties with our SERMs. Remember, you're depleting estrogen, you get osteoporosis, and arthralgia is a significant toxicity that lots of people complain about and is probably related to the highest reason for discontinuation with aromatase inhibitors. Something that you'll see as a commonality across all the hormonal agents is hot flashes, regardless of whether you're talking about the anti-estrogens or anti-androgens. Hot flashes will be a recurring theme. Now, for the anti-androgens, we're talking about testosterone here and binding either to the androgen receptor or depleting specifically testosterone. And so our receptor antagonists, our first generation receptor antagonists are listed here, but we also have second generation antagonists that work slightly differently. And we're going to be talking a little bit about that within prostate cancer. These are drugs that are used slightly differently and in different clinical situations as your first generation receptor antagonists, mostly because of better binding to the androgen receptor. So the toxicities that you're talking about here are gynecomastia is a big deal with some of these receptor antagonists. Diarrhea is also something to watch out for, and hepatotoxicity. Again, these are general toxicities across the board here, and some of these will have more specific toxicities. Testosterone depleters, things that deplete testosterone, just like those that deplete estrogens. We used to use high-dose ketoconazole for a while, but now we know better, and we have something called abiraterone that actually does prevent the synthesis of testosterone. And the toxicities that we have to worry about there are things like hepatotoxicity, electrolyte disturbances. So the last category here are drugs that would actually decrease estrogen and testosterone. That's an and testosterone. These are our GnRH or LHRH agonists. So gonadotropin or luteinizing hormone releasing hormone agonists. And so remember, the mechanism here is that it binds to these LHRH receptors on the pituitary producing cells, which causes an initial surge in LH and FSH, but over time it down-regulates the LHRH receptors on the pituitary so that you would get a decrease then in LH-FSH and the decrease production of estrogen and progesterone. So this is used to purposefully either put people in a postmenopausal state with estrogens or put people into a low testosterone state with prostate cancer as well. And it's a huge backbone of our therapeutic options within breast and prostate cancer. The thing is, we have to be careful about this initial surge in LH and FSH, specifically if we're talking about prostate cancer and people with bone metastasis, because we can actually make things worse in that initial week period of time where you get this surge in LH, FSH, and testosterone. So the toxicities here, again, hot flashes are a big deal, as well as gynecomastia. You can see that with guys who are on LHRH agonists for a long time. So that's it for the high-level overview of anti-estrogens and anti-androgens. I hope you found it to be helpful. If so, give a like. Leave some comments below on what you thought wasn't too clear, what you liked about the lecture, and feel free to subscribe to the channel to view further content. As always, you know where to reach me, and I'll see you in class.